Hello, everyone. My name is Vanessa Hugo. I'm with the Musella Foundation. It's my pleasure today to introduce Dr. Ali Benaim. Dr. Benaim is the Chief Medical Officer and an Executive Vice President for Sonodynamics. He started his career as a pediatric oncologist at St. Jude Children's Research Hospital. He then moved into drug development, taking leadership positions at Amgen, Sangamo Biosciences, Millennium Pharmaceuticals, and others. And just prior to joining Sonodynamics, he was Chief Medical Officer for Novocure. And before I turn the floor over to the audience, there will be a Q&A at the end. So if you have questions during the presentation, please type those into the chat and we'll try to get those covered at the end. Dr. Benaim?
Great. Thank you, Vanessa. Thank you all for having me and having Sonodynamics and in your waves or the great audience. So we're going to talk about a new non-invasive platform on how to treat cancer. And the first indication that we have decided to treat is DIPG. So sonodynamic therapy is a drug-device combination to treat cancer. And we use a drug that we call Sonala 001. It's an intravenous injection of 5-aminolevulinic acid, and I will explain how this works later. And we use a device called Exablade Type 2.0 device from an Israeli company called Insightec. And what we do is we use this MRI-guided device for brain tumors with an exclusive license from Insightec. And we're doing the IPGs. As you can see, this is a hemispheric dome that has ultrasound arrays inside the dome. And then the patient's basically head is inside this dome, and eventually this goes into the MRI machine. So the MRI guides where to place the ultrasound waves. We're also working on a MRI-free ultrasound device, and this is right now a prototype for extracranial tumors, where we initially will try on certain types of bladder cancer, and we're going to expand into other GU and GI cancers. So ALA, or 5-aminolevulinic acid, is FDA approved to image brain and bladder cancer. The most common use is an oral drug called Glioland, which is used to assist neurosurgeons to identify and surgical remove aggressive brain tumors. So the oral ALA is given a few hours before to the patients, and then while the patient is having the craniotomy to have the gross total resection, mainly on glioblastoma multiforme or GBM, the tumor takes into the ALA, and with the blue light, you're going to have the tumor glowing pink. So you can see all this pink that you see in this image is a tumor, and including this is like pseudopods or extensions of the tumor. So all this is tumor, and probably some areas that are not lighting up is also tumor. So the surgeons, will try to take most of this. So this has been used for a long, long time, and it's already approved for that. There's also in bladder cancer, it's been used. This is topical ALA that is injected or given through a cystoscopy. So as you can see, this is a white light image. Then when you turn on the blue light, you can see where the bladder carcinoma is. So there's many solid and liquid tumors that preferentially take up ALA. So one, as I show you, is glioblastoma, but you can see all the carcinomas in general, even low-grade gliomas, meningiomas, etc., will take on ALA and be susceptible to this blue light, and in our case, to sonodynamic therapy. It's also of interest that we can see also this effect in hematological malignancies. So how does this work? And the 5-ALA, or aminolevulinic acid, it is an important component of the formation of a molecule called heme. And heme is in every single cell of our body and is responsible for the transit of oxygen through the cell. So the most common one that you have heard is hemoglobin, where the heme is combined with globin and iron to carry oxygen to different parts of the body. But cells in general don't have the globin, just have the heme, and is what carries the oxygen inside the cells. So what happened is that one of the metabolisms of ALA, or one of the component of the pathway from ALA to heme, is called protoporphyrin IX. So you need protoporphyrin IX plus iron to make heme. What happened is cells that reproduce very, very quickly will have higher needs of iron and will accumulate more protoporphyrin IX. And protoporphyrin IX is activated by light. Correct? It is you activate the protoporphyrin by using blue light, but in our case, we find out that we can replicate the blue light using ultrasound. So the same frequency of the light, the blue light, we can generate that by ultrasound. So when we activate this protoporphyrin IX, the energy release is released as a fluorescence, and then there's energy transfer of oxygen. Instead of making heme, it makes reactive oxygen species, so sort of like toxic species. And they both create either immediate cell death or programmed cell death. So different mechanism. And this, we have seen this in animal models, and our first clinical trial done by Dr. Sanai in the Ivy Brain Cancer Center and recurrent GBM. So just to summarize, it's a little complicated, but imagine that the 5-ALA is a nutrient for every single cell in the body to make a molecule named heme that is necessary for the survival of the cell, because it's the one that carries the oxygen. Cancer cells, since they reproduce much faster than normal cells, have a higher need of 5-ALA, a higher need of iron to make heme. So fortunately, they cannot make as much heme. They start accumulating this protoporphyrin IX, which does not happen in normal cells. So this accumulation of protoporphyrin IX make the tumor cells susceptible to this sonodynamic therapy. Used to be photodynamic therapy, but basically you have to put the light where the organ is, as I show you in GBM. But with focus ultrasound, you potentially can treat any tumor that will be needing 5-ALA, that will be very susceptible then to the ultrasound. Just to show one animal model, and that's where we move into the clinical trials. This is a glioma, an adult glioma preclinical model, where the tumor is placed on the rat, and the animal is treated 3 times, correct, weekly for 3 weeks. So this is the control, and you can see the tumor growing. So then this is animals that receive just the ultrasound, and you can see also the tumor growing. This is another group that only received the 5-ALA, and again, nothing happened. If any, the tumor grew even bigger. But when you do sonodynamic therapy, the tumor was implanted, but then it disappeared. And as you can see on the pathological cuts, the control, the ultrasound, the ALA, but the combination of the focus ultrasound and ALA will give you a disappearance of the tumor. So if you see it in the curve, you can see that, the control, the ALA, the ultrasound ALA, they all grow, while the as sonodynamic therapy group have a disappearance of the tumor. If you look at survival, also, those animals were died before 40 days, while the animals on the SDT group had a complete survival. And because of ethical and animal control laws, the animals were sacrificed by day 80 or 90. So based on this, we move into recruiting patients in a phase 1/2 trial in DIPG. DIPG, or diffuse intrinsic pontine glioma, is a very rare, fast-growing pediatric brain tumor, which make it very susceptible to sonodynamic therapy. The point in most cases, the tumor is in the pons. It's very hard to approach and really eliminate by surgery. Many times these patients are diagnosed without a biopsy, but it's basically overall inoperable due to its location on the pons. And the median survival is around 9 months to 9.5 months. Radiation therapy is really the standard of care. And if you can see the standard of care, then this is unfortunately what we see. Beautiful children that get radiation, and then they have to be in steroids to control the side effects of the radiation therapy. So we started a study called SDT-201, a phase 1/2 study of DIPG, which is already ongoing, to demonstrate tumor regression, extension of survival, with no dose-limiting toxicities or severe adverse events, and a good quality of life. We are looking at meaningful endpoints that are called the RAPNO criteria, PFS, and overall survival. And we started with single doses in cohort 1, and then we basically amended the protocol to treat the patients monthly, and I'll explain this in a second. The sites, we have 3 sites open: Children's Nationals at DC, UCSF Children's Hospital in California, Nicklaus Miami Children's Hospital in Florida, and we are planning to open these other sites: Duke, NYU, Cooks County Children's Hospital in Fort Worth, and MD Anderson in Houston. So on the study, sorry, let me go back one. We tried combinations of drug and the energy level given by the ultrasound to try to activate as much protoporphyrin IX as possible. So we right now are in the last cohort of 10 milligrams per kilogram, and the highest dose, and you have to be careful when I say highest dose. I would prefer to use the word of optimal dose, because with more energy doesn't mean that it's better. What we need is the optimal dose to activate protoporphyrin IX that is in that range of the blue light. So we are right now completed the enrollment in this cohort. We're going to keep putting patients in this cohort until we declare a recommended phase 2 dose, and we will then expand to probably have a total around 27 to 30 patients in this study. So we're very happy in the sense that the safety has allowed to escalate both the 5-ALA or the Sonala 001 and the energy levels, and optimize this dose without any severe adverse events due to either the 5-ALA or the ultrasound. So this is basically then a protocol with non-SAEs or severe adverse events due to the therapy. I want to show you some of the patients that we treat. I'm not going to go over every single one of them, but I'll have a summary of the first 9 patients. If you can see here, this is our first patient. It was, and I have to put a caveat here. The first few patients is 4 or 5 patients. Each one of them got somehow, it's a different type of therapy at a different times, and I'll explain the reason to that. For the first patient, there was concern about potential toxicity and the location of these tumors that could be quite critical and really dangerous for patients. So copying the phase 0, phase 1 that I mentioned at the Ivy Brain Tumor Center, patients that were diagnosed with DIPG were treated under standard radiation therapy. And sort of a month or so after therapy, the patients got half of the pons treated, and then a month later, the other half. And after that, half the pond, the patient the next day had MRI and have another MRI before the other half, just for safety. The point is that this patient really had a benefit of the therapy over time. But if you can see, the patient got the first half, the tumor kept growing, and got the other half. And remember, this is the lowest dose of drug and energy. But then by month 3, you can see already a 37 and then further a 70% partial response, which is very, a considerable reduction for this patient. And one of the things that, unfortunately for this patient, 10% of the patients with the IPG already have undiagnosed leptomeningeal disease. So this is disease outside the pons. And unfortunately, this patient had a progression on the outside the treatment. As you can see, the tumor still was small compared to when it was treated at the beginning. But unfortunately, this patient had a progression outside the treatment area. One of the things that was important is a quite improvement in the quality of life of this patient, with reversal of her double vision and really increasing the mobility and balance from having major issues to balance to doing ballet swirls. One of the things that I will be talking on the next few slides is the issue that we're seeing right now, that there is a lag on the radiological findings and the improvement on the neurological symptoms. So, and we still, again, we're only treated officially, 9 patients. There's still a lot to learn. And the first, 5 have received sort of a different type of therapy. So it is hard to generalize for all these patients, but we can see there's 2 things that we can say. One is that the therapy is very well tolerated, that we see in certain patients improvement in quality of life, and in certain patients there are tumor regressions. This is a patient that have received the longest therapy. If we put the survival around 9.5 months or even 12 months, this is a patient with a smaller tumor than the previous before, but this patient got SDT in November of 22. As a single dose. Later, we amended the protocol because we saw the lack of toxicity, and we started treating these patients monthly without any toxicity in this patient. And this patient basically had a stable disease, a partial response here with some progression. But in spite of that, the patient still, when you saw some progression here, the patient still had no changes on their neurological symptoms. That may change over time, but at this time, when we took all these images, even though it looked slightly bigger, we are not completely convinced that this is tumor growth. We think that there may be some effect of the therapy. There's something called pseudoprogression, and we're still not 100% clear when to call it, but the protocol allows treatment through this progression as the treating physician thinks that the patient will benefit. There's patients also have shown stable disease and then progression. This is a patient that got only half a full therapy, and then a month later got 2 more therapy, and then he was out the trial. I'm not gonna go into every one of them, but I want to show you is the summary. So these are the first 9 patients that have been treated, and I will say the first 4, you know, and maybe the fifth are a little different than the ones that we started treated from November on. You know, as you can see, these are the patients that got half of the therapy a month apart. This is a patient that got the therapy, you know, 9 months after the initial therapy. This is a patient that got therapy, and then 6 months later got 2 therapies, and then was off trial, etc. But as you can see, so far, and the first, you know, if you put the first 5 patients, right, 4 of the 5 have a survival over 12 months, right, which it is already encouraging. But again, this is early time for the protocol. I think these patients here, you know, from November on, which are already getting higher doses and probably a better energy, and some of the patients are going to probably be added to this cohort 3. We hope that these patients will have an increased survival. One of the things, though, that we have seen in the first patient is that many of them regain or retain function after sonodynamic therapy. So, you know, this patient had trouble walking, improved the mobility, had a nerve palsy and double vision that was corrected. Patient number 2 had a landscape score that was maintained, or a performance score with maintaining the weight. Patient 3, again, you know, and so forth, you can see that the patients had before and after benefit. So I'm going to move from the DIPG now, just briefly on GBM. GBM is most common aggressive brain tumor in adults, and there's around 10,000 cases per year. And the universal mortality and median survival is less than 15 months. Usually you get surgery and chemoradiation with maintenance with temozolomide. And we are trying now to treat these patients from, you know, from a lethal at least to a chronic stage. 5 sites are active for enrollment: IV, Cleveland Clinic, Mayo, UCSF, and NYU, with other sites opening. And we are right now, we put another cohort to cohort 5 that we're calling to treat patients. So we still not close to the recommended phase 2 dose. So I'm not showing any scans. We have seen some activity, and also not severe adverse events due to either the ALA, the ultrasound, or the sonodynamic therapy. And the idea is to complete the recommended this phase 1 and call the recommended phase 2 dose and go into the expansion. Just in conclusion, though, I think sonodynamic therapy provides many advantages over current treatment options. And this is, you know, current treatment options are not only for brain tumors, for any cancer, surgery, radiation, chemo, antibodies, ADCs, CAR-T, versus sonodynamic therapy, where we give in just once monthly, a non-invasive outpatient procedure. These therapies have significant toxicity, side effects. They're limited how much you have repeated treatments. There's limited efficacy and the potential tumor resistance. Sonodynamic therapy enables repeated treatments, selectively kills tumors and not the normal cells, because the normal cells do not accumulate protoporphyrin IX. It is well tolerated. It's unlikely to create tumor resistance, because the tumor needs ALA to survive. It really doesn't matter if it has a mutation or methylation, because it is a metabolic therapy, basically, where we're using the metabolic machinery of the tumor cells. It really doesn't matter which mutation they have. You don't need a biopsy to treat these patients. And so far, it seems to be effective as monotherapy. And I think that will be it for me.
Thank you so much, Dr. Benaim. And just to reiterate how truly groundbreaking this is, for DIPG, the typical prognosis is somewhere between 9 to 12 months. And so to see these patients, having extended life and having real quality of life during that period is really exciting for a disease state where there's basically, no other good options. So we're big fans of this therapy, and we've had some questions come in if you have a few minutes.
Yeah, well, if I just want to make one point also, this therapy, we're learning, obviously, but every patient, every therapy is really very personalized because we can really target exactly each area of the tumor or the brain and how do we want to treat it. So when we see a change from one scan to the next scan, correct, you can make modification. The neurosurgeons can say, this area is already necrotic. I don't need to treat it, but this area looks a little more enhanced. I'm going to treat it a little bit this other way, and we're going to have parameters, correct? It's not like crazy, but imagine this is like doing surgery without the scalpel, correct? You can go every time, and it's really that radiation, because radiation, you may modify your fields, correct? If you say some tumor reduction, but at the end, they're going to get the totality of the radiation with the side effects. Here, if we put the ultrasound in areas of normal brain, nothing is going to happen. The frequency that we use here of ultrasound, this is a very low frequency ultrasound, the same that you do for pregnant women to look into the fetuses, correct? So it is no risk, and there's no risk on the 5-ALA. It's just the combination is what makes the magic. Basically, it creates a smart bomb that releases all this toxic oxygen and destroy the tumor cells.
That's great. And actually, when you talk about tailoring it, sorry, I'm going off video because my video is freezing, but when you talk about tailoring it to each patient and each tumor, can you talk about how large of an area you can treat? Like, is there a parameter limit on the tumor volume or going beyond the tumor volume?
So I'll talk about GBM because those are big tumors, and we have been able to treat bihemispheric tumors, like really, really large, that occupied a third of the cranium without any major side effects, correct? And we have seen activity. I'm not talking resolution, but we have seen, activity in those tumors. So the beauty, even though this is focused ultrasound, we really are not. We don't need to be that focused, correct? We can be as focused as we want. We are not opening the blood-brain barrier. We're not attacking directly the tumor. What we're doing is activating a drug, and that drug then causes the effect, and it's a drug that is needed for the tumor cell. So it is, we can open, let's say, the field as much as we want. For example, in the bladder, correct? We can treat the whole bladder, even if the tumor is in a very specific area, but the concern is that there may be tumors somewhere else. And if they are taking ALA, then they will be susceptible to that. So we can treat then large tumors that other therapies can.
Okay. And going specifically to 5-ALA, is there a difference in uptake, between DIPG, between GBM, between other types of, tumors?
Yeah. So in general, no. One of the advantages that we have with Sonala 001 is given IV. So it bypasses the absorption of this, variability of absorption in the stomach and the pass by the liver. So we already have presented some early data on the pharmacokinetics, basically how the drug gets metabolized IV, and is very predictable. So we know that we're getting enough 5-ALA and the tumors. There is some preclinical work that was done to see the susceptibility or I would say the avidity of the DIPG cells in culture for 5-ALA, and it was quite impressive. So we are very sure that the tumors are getting the amount of 5-ALA that they can, and the amount of ALA that is captured by the tumor cell depends on how fast the cells reproduces. So the fastest the cells, they're going to grow, they require more 5-ALA, so the uptake will go up. So the IPG, unfortunately, it's a very aggressive tumor, and that's why we picked this tumor as one of our initial therapies.
Okay. And how long does the dye stay in the tumor cells?
Right. So for, I won't call it a dye, but I would call it as the susceptibility or the protoporphyrin 9 susceptible to the light or sound. It's usually, we like to peak around 6 hours, but for example, in patients with GBM that have received the oral formulation and they're gonna go for surgery, and then something happened and the surgery was postponed for the next day, you still see that. So I think at least we know that probably there's susceptibility for 24 hours, but we like to peak around 6 to 8 hours to give the maximal penetration. Remember also that we're giving this monthly, it's not only one shot. So, whatever we didn't do the first, maybe we'll get it the second time. But we think that, 6 to 8 hours is a good time to give the sonodynamic therapy.
Okay. And that brings me to another question. So how long does each individual treatment take? And then you mentioned doing them monthly. So how did you arrive at that kind of monthly cadence for repeated treatments?
Correct. So I'll go for the repeated treatments first. And if I asked the person that did a lot of this work and did the work on the gliomas on rats, and I asked him, how frequent will you treat patients if you could? And he said, well, I will treat them daily. Like, I think this is a process of really hitting the cells as much as you can, correct? Obviously, we cannot treat right now daily with this the technology that we have, but hopefully we could treat in a different way, and we already think about ways to treat in an easier way than we're doing now. But after I saw that the patients were tolerating after a month the therapy, and see some of the responses just with one therapy, we decided that we needed to treat these patients more frequently. So for practical purposes, more than anything, a month. Most of the oncology drugs, etc., are given every 28-day cycles, and the hospitals, the clinics are their flow, their routine is around 3 weeks to once a month. But really, this is completely empiric of how we treat it. It's just to treat the patient as much as possible. We have not seen toxicity so far. We see a toxicity after 12 months of therapy. I don't know. Should we treat this patient 3 months in a row and give him a break for 3 months and then 3 months later? I don't know. I think, in cancer in general, you treat as much as you can. And that's where we treat it monthly. The patients are tolerating it well, and we're doing the best we think for the patients. The other question is going to come, for how long to treat them, and that's another question that I don't have the answer yet. And right now we treat it for as long as we can. But we're going to have patients that are being treated for a year. Should we continue treating those patients? Should we give them a break? And these are discussions that we have to have with the community, the DIPG, key opinion leaders, etc., to see, until we should treat these patients, correct? And I know there's people that would say treat them forever, which I already, and others will say, well, show me that you're providing a benefit. So still is an open question. The other thing is how long did the treatment last? And it depends on the size of the tumor. So for children, since the tumor is not as big as adults, usually it's around an hour plus minus, correct? From 40, we have treated patients from 45 minutes to up to 2 hours. The inconvenient with the children is because this is in an MRI, they have to be sedated so they don't move when we do the procedure. So and they have to receive this IV a few hours. So it's a full day, and right now they stay overnight in intermediate or ICU for neurocheck. We plan to change this soon, where the patients may not have to stay more than one night in the hospital, and if possible, do it as an outpatient. We just, again, we have treated 9 patients and DIPG, a couple more and this study, a couple more on compassionate use, plus the patients, the adults that we have treated. The adults takes a little long because of the type of tumor. So it's usually around 2 to 3 hours, but they don't need to be sedated in general. If it's going to go beyond that, then we suggest to sedate the patient because it's too long. The major complaint from the patients, both the pediatrics and adult, is hypothermia because or basically low body temperature, because there's a ring with water around the head on this helmet that or hood that the patient had, and then the anesthesia brings the body temperature down, and the MRI rooms usually are very cold because of the machine. But now there's all this arrangement for the room, and blankets, etc. So that has not been an issue anymore.
Is it possible, at some point to not have it MRI guided and just to treat the entire brain?
Yes, so that's part of what we're working on, and there's different people that is doing this type of thing. So eventually we'd like to have an MRI free, the same way that we're looking for outside the brain, to basically do this in children. So still working on the engineering of it, but you can imagine, correct, that the child coming in the morning, getting the IVs, going, with the parents to whatever, come early in the afternoon and get some type of device, helmet or something like that, and play video games, correct? While he's getting the therapy for an hour, and then go home, and maybe come the next day or 3 times a week, or so we can. The technology is getting there, but right now, we are married to the MRI.
Okay. And I do want to just stress, one of the reasons we are excited about this treatment, really love this treatment, is that it is non-invasive. You get your IV injection, you wait a couple hours for it to uptake, you have the focused ultrasound applied. But after that, you have DIPG patients, dancing in their room, after the procedure. So
Yeah, and then they go to school the next day or they travel. So really, that's why we push it monthly, correct? It is it is a little tricky though, because now that we're treating patients monthly, there are patients that are doing well. So now sites are getting, they have to have, let's say, if they have 1 spot a week to treat this patient and they have 4 patients in therapy already, those spots are taken. So now you have to find another spot for new patients, correct? So that's where we're trying to open new sites, and we start already feeling the crunch of patients that want to participate, that we are trying to accommodate. But it's going to depend more on the site than anything else, right?
And on that note, can you talk about, just for a quick minute, on the eligibility requirements for both the DIPG trial and the GBM trial?
So the GBM are easy, so I'll go first with Y1 because these are recurrent GBM, and there's no limitations how many therapies they have received before, and there's no limitation on the size of the tumor. So that's why that protocol has been very popular in the sense that other protocols will not take patients that were re-resected, re-radiated, have received, Avastin or
Is there a limitation on the location of the tumor or multifocal tumors?
no, no, that's the beauty of this, correct? So there's other therapies out there that cannot treat bihemispheric tumors. We have done it, and we don't have a problem. It's just it takes longer, correct? It's a procedure that take a few hours then if you have a very large. Um,
And could participants in the recurrent GBM trial, could they also use Optune while in the trial?
yes.
Yes, okay, great.
So for DIPG, you can go to clinicaltrials.gov and look at eligibility, but in general, patients have to have a diagnosis of DIPG and have received the standard radiation therapy and not anything else. They could have received steroids to control the side effects, but have to be on a stable or a winning dose of steroids, and it can be on anti-seizure medication, but then any other interventional medication or cell therapy will make the patient not qualify for the study. We'll take patients with shunts, correct? It's just we need to, find out how to treat the ultrasound around the shunt, which is done. But the tumor has to be limited to the pons, correct? It can right now we are not treating DMG patients. We hope to get an approval soon to do an expansion of 10 patients at DMG. But this is we first have to declare the recommended phase 2 dose in the DIPG before we move into DMG. So I hope probably by mid-year we'll start treating patients with DMG.
Wonderful. And I think maybe as our final question, I'll just ask, this is really exciting therapy. And as you said, you have a lot of patients interested in the trials. What do you see for, the path forward with FDA approval? What's the path forward? What's the time frame? And what else is needed for FDA approval?
Yeah, so I think one of the reasons we picked DIPG is because it is the concept of really an orphan disease. It's really a rare disease. It's a small population in the world of pediatric oncology, but it's a unmet need, terrible unmet need. So the FDA, and we had a meeting at the end of last year, is very cooperative on how to get this therapy to approval if we get to certain endpoints which had not been defined yet, correct? So this was our first meeting, more about the safety and how we're going to look and how to get this for approval. The challenge is that this is a small population, and I think the FDA recognized that we're never going to do a randomized double-blind placebo-controlled study, correct? There's no way we're going to do a phase 3 with 500 patients. That's not going to happen, correct? So there are some databases that still have not been validated by the FDA to use as a competitor. But I will say the 3 medical reviewers, including the head of the division, are pediatric oncologists, and one is a pediatric neuro-oncologist. And really, they were very positive and tried to find ways to get this forward. I think, and eventually, and this is complete speculation of mine, part is there has to be some adoption of this rare diseases into oncology, which is not very common, correct? When you do rare diseases in non-oncological, you don't need that many patients for approval because there's nothing, and you don't, the level of proof is not that high. In oncology, it's the gold standard in clinical research or clinical development, and everybody copies what happens in oncology. So the gold standard is higher, which we will, DIPG will not be able to reach a very statistically significant endpoint. So this is up for negotiation. The point is that certainly overall survival will be then, the major endpoint. And we're already seeing, patients that are passing that, 12 months. So we hope if this continues in most of the patients, that this will give us more ammunition to try to get through the regulatory agencies. I would say that the FDA and the EMA are very open to look for a solution or some type of therapy for the DIPG patients.
Okay. I mean, it's great to hear. We're hopeful for that flexibility. And of course, there's a huge unmet need there. So
yeah, I would say though, just for you guys, the community has been a big part of it. I think the patients group, families have been, in Washington with the FDA and have pushed to have this conversation. So I'm very happy to see that, and I think that will continue. So the voice of the patients and their families is being heard. So I'm grateful and to you guys for what you're doing.
yeah, absolutely. And just one last quick question. Do you think that prior to approval, there might be a possibility for expanded access at some point for those who are not eligible for the trials?
Right. So remember, this is, we need to have a device, right? So this is the limitation. So that already limits how many patients can we treat and where can we treat it.
Mhm.
That discussion will have to be done with the FDA. We would love to do that, especially if we can somehow charge for it, because then it's a very expensive therapy. But even if we cannot charge, but we can support it financially, we will be open to that. The other question will be, should you take that time to maybe combine it with something else, correct? So there's many possibilities. We're open to them. But right now we haven't had that discussion with the FDA. It's a little premature.
Okay. Well, I think that's it for questions. I just want to say thank you so much, Dr. Benaim, for your time. Thank you for all the work that you're doing for everyone at Sonodynamics. We're really excited about this and hope to see more positive evidence, in the future.
Yeah, thank you very much. I appreciate Al, Vanessa for doing this, and I'll take the time to tell people, I know how hard it is, and I have my own, family issues that have to deal with cancer. And one of the reasons I'm a pediatric oncologist is because I had a cousin that had a pediatric leukemia, and that impulsed me or pushed me to become a pediatric hematologist oncologist. So my heart goes to you. I know how hard this is, either in pediatrics or adult GBM, and trying to do the best we all can. Keep pushing. Hug each other, love each other. I'm here to help. Hopefully, pass the boys out there. We still need funding. So if you know some billionaire or millionaire that wants to help, talk to Al. He'll help us and figure out a way to keep pushing this therapy in cancer patients.
Great.
Okay.
Thank you.
Thank you very much, both of you. Very good presentation. I'll
Thank
see you
you.
next time. Bye-bye.